Hello. I think I'll start talking. I think people are starting to trickle in. Oh, hi. How are you? It's so good to, it's so nice to be here. My name is Amelia Bachman, and I recently joined the Delaware Institute for Reproductive Medicine, or DIRM, as we like to call it, which is now part of the Boston IVF network. I'm really happy to meet you all today and answer some of your questions, so please feel free to reach out. A little bit about me. I'm from Pennsylvania originally, and still live here, but Delaware is very close. And I was trained at the University of Pennsylvania, and recently came from there. And I'm really happy to join Dr. Russell and our team at DIRM, as well as one of my colleagues, Dr. Kovalevsky. He will be joining us really shortly. So we're really excited to take care of you and to continue to grow the practice and offer you really amazing care. So I'm really happy also today to answer some questions for you. Oh, thanks so much. Thanks for saying hi. It's so nice to have you here. I think we can just start. I mean, if you don't have any, if people who just want to just put some questions out there, but we did have some that were sent to us prior to the video. So this is a really good question. So someone asked, after having my first child, how long before starting treatment? So typically, we do like people to wait at least a year between children, just for the safety of the pregnancy. There are some data on, increased miscarriage, growth restriction, when pregnancies are too close together. That having been said, each person's individual goal may be different. So if based on age you're nervous to wait a bit, it always might be good to have at least a consultation. And sometimes we can, maybe get some treatment started before even getting you pregnant, getting some testing done, getting some things done. But we do like to wait at least a year beforehand, before you have another transfer. Oh, hi. People saying hi. Hello, everyone. It's so good to see you. I'm so happy you're here. Maybe I should take a step back too and just talk about, what you might expect at the first visit. We do like to take time and talk to you about what has been going on, what your goals for your family are, take a really complete, history, your medical history, previous gynecological history, pregnancies, if any, for both partners. As we take care of both, all kinds of families, both patients in opposite sex relationships, same sex relationships, single patients. So we have a lot of options for everyone, but we do want to make sure we find out what your goals are for your family. And we do then we take an approach to test, to look at egg reserve, uterus, fallopian tubes, sperm factors, or to talk about donor sperm if that's what you're using. Also some of our couples are looking at using a gestational carrier, a donor egg. So there are a lot of options we can talk to you about, and so we just want you to let us know, and we'll take time to talk about this with you. Oh, so nice. Someone said I was there shadowing the transfer. That's so great. So this is a great question. When do you recommend growth hormone priming? So this is a bit controversial, I will say, as this is not an FDA indication for using growth hormone. There are some small studies in IVF, in the IVF literature, that look at embryo development. So when people make embryos and perhaps the embryo development wasn't as good as they expected, or for some egg maturity as well. And so there's some various protocols, although it is important to know that we don't have the randomized controlled trial that tells us that this is definitely going to help. I've seen many people use it around, and there are some protocols that have been used in small studies, but typically it's for blastocyst development or egg maturity. But again, it's important to know it's not an FDA regulation use of this medication. But sometimes we have tried it for some people, particularly when they haven't had other success with other treatments. Okay, these are really good questions. So another one. There's someone, I'm really sorry about your miscarriage. I know it's really hard. My heart goes out to you so much. It's not easy. So big hugs from me. And, certainly, one that's the most important thing to know is that there's nothing you did wrong. This is common, but it is really, really sad and it's really hard. And we are here for you. It is important to talk with your doctor. It is very reasonable to have an ultrasound to make sure that is resolved. A large majority of miscarriages are caused by sporadic genetic abnormalities, meaning the random egg and sperm came together and were not viable. Does this make it easy? No, not at all. It's devastating, and you do have to take time to grieve that. Medically, most patients will be able to, conceive again, but it is good to get some help if you're having difficulty getting help, or if you've had 2 or more miscarriages, we should do a full recurrent pregnancy loss workup. And that includes, a uterine cavity evaluation, some tests like thyroid, diabetes screen, the antiphospholipid syndrome, looking at some immune factors, chromosomes of both partners, thyroid antibodies, we check prolactin. So there are many tests that we check to see why someone had 2 or more losses. Typically, especially if you've had 1, that whole workup is not recommended, but you might do some pieces of it that might be helpful to give you some peace of mind. Okay, hope that's helpful. This is a good, you don't have to be sorry. Every question's great. What does it mean when doctors advise to take it easy with exercise? So this is a great question. So what I would say is if there's something that's normal for you in just kind of your normal life, if you're not doing IVF, so we'll talk about non-IVF, just getting pregnant or just doing some less invasive treatments like inseminations, medications, you should be able to do what's normal for you. Certainly, we don't want you to over-exercise. So I think if you are, really intensely, running, excessively more than an hour a day of physical activity, you may want to tone that down a bit. But what's normal for you, you should be able to continue. Now with IVF, our ovaries get very large and they become the size of grapefruits, and we're worried about something called ovarian torsion, which is the twisting of the ovary. So we don't want you to exercise at all or have penetrative intercourse, because the ovary can twist on itself, and that is a surgical emergency called ovarian torsion. So most people, what we say is during the IVF cycle and even the 2 weeks after, because after the egg retrieval, it can take some time for that ovary to get back to its normal size. So we don't want you to exercise at all. Walking is okay, driving is okay, you're normal. It's like I call it doctor prescribed laziness. But outside of the IVF cycle, you should be able to do what's normal for you, but I would not, more than an hour a day, or, more like, and then getting your heart rate really, really high, you probably want to limit that. As far as how heavy you can lift, if you can lift heavy, weights, if that's normal for you, that's okay. Again, during the IVF cycle, when your ovaries are large, you probably don't want to do that. We also tell people to limit some activities after the transfer. We all know people who get pregnant exercising and doing things, but we've put that precious embryo right in that right spot, and we just don't want you to do anything excessive. But the important thing is you don't have to lay there. There's no amount of bed rest that has been proven to improve implantation. So we don't want you to feel like every little movement is going to hurt something. But it's probably not the time to climb Mount Everest. It's not the time to do something you're not used to doing. So I do also tell people that, if you're not used to doing really intense exercise, it's not the time to start right now. But just moderate exercise is really good for everyone, and you can continue that. I hope that was helpful. And then, oh, you also said after being pregnant too. So the same thing goes with pregnancy. You should be able to exercise. Exercise does not cause a miscarriage, but again, do what is normal for you. Okay. Um, how soon before my cycle do I have to stop breastfeeding for an IVF cycle? This is a great question. So even if you're breastfeeding a little bit, the hormone prolactin can affect how you respond and implantation. Also, we don't want the baby to get the IVF drugs, right? We don't want the baby to get the gonadotropins, FSH and LH and things like that. So typically, we usually tell you maybe the month beforehand. But if you're only breastfeeding a little bit, if your baby's eating a lot more, you can probably just stop a few weeks beforehand or so. But we do want you to stop that because we don't want the baby to get the hormones. Okay. This is a good question too. They're all amazing questions. How old is too old and how young is too young for IVF? This is a great question. So I think we have to go back to what is the indication for the IVF cycle, right? So typically, if someone is trying to conceive and they have blocked tubes, the sperm is low, they have tried other treatments that haven't worked, they want to do genetic testing either for something they know they can pass on, or they want to do preimplantation genetic testing beforehand. If they have severe endometriosis, these are some of the many reasons for doing an IVF cycle. As far as too young, I mean, we really see that probably your better success is 21 and over. That's our ideal age for the egg donor. Certainly there may be someone who's between the ages of 18 to 20 who wants a family who may have issues, but your better success is in that early 20s and then moving, and then it does go down as we get older. Now, how old is too old? So typically we see that after 40, success rates go down. We do think that IVF works the best for patients between the ages of 38 to 42. That's probably going to be your better chance for success versus doing IUIs and other treatments. It seems that some studies have shown us after 43, the success rates even more dramatically increase. So you are having lower success between 40 and 42, but we still have a lot of people who conceive. And then after 43, this really drops off. So some offices do have a certain cutoff, basically because the chances are no different than potentially trying on your own, again, if you're with an opposite sex partner. So I would say probably after 45, 46, your chances are going to be much better with a donor egg. That having been said, there are some individual situations, and I always have an individual conversation with my patients about what is your egg reserve, what is the success of this treatment. It is important to know that unfortunately age is the primary predictor for pregnancy. So we don't want to do treatments that aren't going to help you either, but we also want to help you have your family in the way you want to. And for some patients, they may not want to use an egg donor. They may want to have that chance. And certainly I believe everyone deserves a chance, but we also have to have an honest conversation about what the real success rates are, because, we don't want you to go through treatments that are not going to work for you. But certainly the chances go down. It's not an absolute. Most people say maybe after 45, 46, it may be better not to do your own IVF cycle, but the chances are low after 43. Okay. What exactly does the Receptiva test mean? If it's positive, does this mean for sure that there's endometriosis? So the Receptiva identifies an expression of something called the BCL6 receptor. This is a marker of inflammation in the uterine lining. And so what they say, it's an over 90% sensitivity and specificity that someone would have endometriosis. Of course, it's not perfect. The gold standard for diagnosing endometriosis is a laparoscopy, where we put a camera inside the belly button and we can take a look inside and see if there's endometriosis and then try to treat it at the same time. For some patients who've had unexplained, miscarriages or implantation, implantation failures, it may be a good way if they don't want to have the surgery to test for that. I think we need some more data on it, but it does seem to have a pretty good sensitivity and specificity for the endometriosis, but again, not 100%, but it's still, it's a tool that some people are using, and I think we need some more data, but I've done this for some patients who wanted that. When can I do an FET after having a baby? I answered this before. It's always good to have, you can have the conversation. We do like to keep them at least a year apart, but it may be good to get the process started. Let's take a look here. It would be very fun if you could talk back to me. It would be really nice. Another person asked a question. My husband and I want to have a girl. Can we choose the baby's sex? So the best way to do this is with in vitro fertilization and preimplantation genetic testing. I always do warn people of doing this when they don't have an infertility diagnosis, and that they're going to go through, treatments that they have to pay for, treatments that they may not necessarily need. But again, I do believe in patient autonomy, and if that's something that people want for family balancing, I support that. But it is important to talk about all the risks and benefits. It is putting yourself through an IVF cycle, which is 2 weeks, 9 to 14 days of injections, monitoring visits, an egg retrieval where you go to sleep. We do an ultrasound guided needle aspiration to get the eggs out. We take the eggs out and then we put them together with sperm. It is important to know that unfortunately there's no guarantee. You could go through this process and you may only have genetically normal males or genetically normal females, and you may want the opposite. So unfortunately, we can't guarantee a result, but that's the best way if you wanted to do some family balancing, is going through IVF with preimplantation genetic testing. Before, some people did do some sorting with IUIs and things, but we found that it's not necessarily much better than 50%. So really it's the IVF with preimplantation genetic testing if you want to do that, and again, it's not a guarantee. Someone asked, does the Mucinex trick really work? So Mucinex, if you don't know, is something that is used for people to loosen the mucus. It's glyphenicin. And so what people, anecdotally, there was an old study, they thought maybe it could thin the cervical mucus more to help that sperm get through the cervix better. We don't have definitive data. It certainly doesn't hurt you at all. Certainly we do want you to be concerned about just overusing things that may not have great data to them. Certainly I don't think it's again, it's not going to cause any harm, but again, the data is not definitive, and it's based on an old study. But that's the reason, is that thinning of the cervical mucus to maybe help that sperm get through. Oh, I love all your messages. They're so nice. And I'm sorry, bear with me. This is the first time I've ever done this. So okay, so this is a great question. Can you tell us the difference between a hysteroscopy and HSG test is? This is an awesome question. So hysteroscopy, hystero is the uterus and scope is a camera. So hysteroscopy is placing a camera inside the uterus. So remember, our cervix is like a little donut hole, and the camera is really thin, thinner than my pinky. And we just gently place it inside there to look inside the uterus, to see the inside of the uterus and see if there's a polyp, a fibroid, scar tissue, see if there's an abnormality to the uterine cavity. So basically we're just seeing the inside of the uterus, and we see the openings of the tubes, but you can't see the tubes and you can't tell if they're open. A hysterosalpingogram, or HSG, is hysterosalpinges, right? So the uterus and the tubes. And then what we do is we place a small speculum in the vagina, also put a tiny catheter, inject a water-based dye, which you can see the contour of the uterus, and then you can see the fluid going through the tubes, and we take an x-ray. There's another type of test called a saline sonohystogram, where we do the same thing with saline and we use an ultrasound. So again, we put the saline in, you can see the inside of the uterus, and then you can try to see the bubbles going through the tubes. So you might say, okay, like which one of these do I do? Well, for the hysteroscopy, it's just a definitive, you're directly looking at the uterus, you see exactly what's there, and potentially you could fix it at the same time. You know, we do some of these in the office that under, you know, when people are awake, because it's a really thin camera, but I wouldn't be able to take out a polyp or fibroid because that would hurt too much. So then we would go to the operating room and you would go to sleep for that. That's the best way to look at the inside of the uterus. For the HSG and the saline sonohystogram, the HSG takes an x-ray, so you can almost see what's called a filling defect. You see, like if there's a little polyp or fibroid, you would see like a blank space. That's that little ball. And but it goes so fast, sometimes it's not as sensitive for the inside. So I do like the ultrasound or the hysteroscopy better for the inside of the uterus. But you can see the contour of the tubes and see if there are any adhesions or scar tissue on the HSG, which it's hard to see with the saline test. Sometimes you can't see those bubbles or you're not seeing the outside of the tube. So typically I have patients who've had maybe multiple pelvic surgeries, pelvic infections, a ruptured appendix, or if they've had, you know, multiple ectopic pregnancies, I would say maybe an HSG is better. Someone who's had none of those risk factors, maybe the saline test might be okay. Okay. Other questions? Oh, so nice. It's so wonderful to see these messages. So I have someone said I got surgery for endometriosis, and polyps 3. Oh, sorry, this keeps on popping up. I apologize. Okay, and I was on treatment for 3 months because I was in a risk of cancer. So if I want to do the IVF, do I have to do all the exams and the biopsy before? This is a really good question. So you may not need to do all of that again. I think if you did the, I think what I'm understanding is maybe you had hyperplasia, which was the precursor to endometrial cancer. So what happens is sometimes the lining, when it gets thicker and thicker, the precursor to endometrial cancer is endometrial hyperplasia, which we can treat with progesterone. And then typically if it goes away at the biopsy, then you can continue to conceive. I think it might be smart at minimum just to do a biopsy and make sure that didn't come back. But if it's been 3 years, it may be good. I always tell patients if you haven't had testing for more than a year, it may be good to update that testing. The egg reserve, the thyroid, or the preconception labs, all those pre-pregnancy labs. You know, if you have endometriosis and it's been 3 years, it might be good to see if the tubes are still open and make sure that hasn't grown back. Check the uterine cavity and do a biopsy. Do you have to do the surgery again? Not necessarily. If all the testing is normal, you may not have to do that again. But it might be good to check and make sure things haven't come back to give you the best chance for pregnancy and so we can decide the best treatment for you. I'm almost 40. Is it too late or less effective at this age if I want to do IVF? I think IVF at 40 would be your best chance for success. Again, not knowing all the other things, it would be good to get the updated testing, but that would probably be your best chance for success given the age and the endometriosis. Unfortunately, the success rates are lower, but I wouldn't wait much longer. So it would be good to see someone and to get that process moving to see if you're a really good candidate, because many people may need more than one cycle. And as I said, you see that 38 to 42 is more ideal than 43 and above. Okay. Can having 1 to 2 drinks per week impact my ability to get pregnant? Is it just best to cut it out completely? This is an amazing question. So everyone may give you a little bit of a different answer. I'm an everything in moderation person. We do know that during pregnancy, there's no alcohol is recommended. We do not know the dose that will cause fetal alcohol syndrome. So we say in pregnancy, no alcohol. We certainly believe when you're trying to get pregnant, it may be better not to drink every day or to excessively drink. But if you're having 1 or 2 drinks per week, we don't have any data that that's necessarily going to help you to conceive just cutting that out completely. It's not fair to you too, because we do a lot of things and it can be very stressful not getting pregnant, thinking I'm doing everything right and it's not happening. So it is important to live your life as well. In this same theme, I think it is important for us to be as healthy as possible, good fruits and vegetables, good proteins, good fats. But again, you have to live your life too. There isn't some diet that's been proven to help. And it's not a one size fits all for every person. So it is important for us all to be as healthy as possible, but we do know people who don't eat healthy, you know, can still conceive. But if we're trying to conceive and it's been difficult, it may be best to try to do everything we can, but also be reasonable with yourself and be kind to yourself too. We know for sure we should, you know, smoking, we should not smoke. Like that's definitely an important thing that can affect our eggs. It affects our chances for fertility. It affects, you know, our egg reserve. It can cause early menopause. So we definitely don't want any smoking. As far as caffeine, you may have caffeine, but we just recommend less than 200 milligrams a day. So 1 or 2 cups of coffee or tea a day, not excessive, like 5 or 6 or more than that. Other things, again, moderate exercise, like we said, and of course, taking a prenatal vitamin. That folic acid has been proven to prevent spina bifida and anencephaly. Also, the omega-3 fatty acids, the DHA, is important for the brain and eye development of baby. And I also believe a lot of us are vitamin D deficient, so it's good to add some more vitamin D. How many failed IUI before you recommend IVF? So if typically many people say, you know, you could 3 failed IUI and then move on to IVF. Although if you're older, if between the ages of 38 to 42 or older, there may be merit to just moving directly to IVF sooner than that. Certainly if we're doing the IUIs and we see that the sperm numbers are lower than we expect, we also may go to IVF sooner. Of course, it is a conversation. What is your medical diagnosis? You know, what are your goals for your family, and what kind of treatment do you feel comfortable doing too? You know, some people, you know, I've seen many patients at 40 years old who look at me and they say, I understand that you're telling me IVF is going to offer me the highest chance for success, but I'm just not ready to do that yet. And so I think we have to come together to the plan that works best for you, and that what is the right medical, you know, decision, what is the right, you know, decision for you emotionally, physically, how do you feel about the treatments? Are there treatments you may not want to do? And then of course, this is my least favorite for all patients, like, do you have insurance coverage? What are the financial aspects too? But it is important because it's really important for everyone. I wish that wasn't a factor at all. And so, but those are important to take all that into consideration and make the best plan for you individually. I also hear there's a lot of amazing questions. Thank you so much. What can a patient do if they've had multiple implantation failures with donor embryo and then one resulted in a chemical? So I think it's important to take a step back with your doctor and look at each cycle. What was the protocol? What was my lining? What was my estrogen? How did the embryos look as well? You know, is the uterine cavity normal? You know, are the blood tests up to date? You know, and so that's important to take a step back there and say, okay, can we change the protocol? Is there some test we missed? And that's important to have an honest conversation with your doctor. You know, I also always recommend to my patients, and listen, I tell people to do this too. Sometimes if things haven't worked out, you can get a second or third opinion. This is your life, and it is important. It's good to talk to someone else, get a different perspective. You know, we're all here working together. We want to help you. We want you to get pregnant. You know, I don't need you to go through multiple cycles and you have to get pregnant, you know, in my office. Of course, I'd like that. I'd like for you to get pregnant, and I want you to get pregnant quickly. That's what I want for you. But it is important to be able to get those answers, to have this conversation. And if you want to get another opinion, you can do that as well. That's really when I always encourage my patients to do that. And we're all very open about that. Any tips for helping an embryo stick and go into live birth? That's a really good question. Unfortunately, We don't have great data on like a position you should be in, amount of bed rest. Actually, we don't think bed rest necessarily helps you, but again, we don't want you to do anything too intensive. But I don't think you should not overthink any movements. We don't think there are any supplements that'll necessarily, make it stick more. I think it's really how is the uterine lining, has all of your testing been done first, right? Do we know that your cavity is normal, your thyroid is normal, other tests are okay? Do we know that the lining and the estrogen levels, the timing of the progesterone, and then what is the quality of that embryo? Is it a tested embryo? And of course, the primary predictor is the age, like how old are you and what is the chance of success? Of course, with a tested embryo, then it's going to be similar across all age groups. How often do you see success after a failed retrieval round? I hear it can take a few rounds, mentally preparing mentally gearing up for a second round next month. Looking forward to meeting you. Oh, so nice. Oh, looking forward to meeting you too. I'm so excited. Again, it depends on age, right? So age and the diagnosis. So some patients are successful after one round. Many patients need more than one. Again, it's all dependent on age. So typically younger patients get there faster. Older patients may have to do more rounds, but I've had opposite things too. I've had some patients over 40 who have a very, who respond really well, and we find those healthy embryos and they get pregnant. I have some younger patients who have an egg quality issue or a sperm quality issue and they're going through multiple rounds. So it is hard. I say hang in there. Again, we always want to take a step back. What is the protocol we're doing? How did you respond? Every time you do a cycle, we do learn from how you responded before. So we do like to say, okay, what should we do? Sometimes we don't. There are some patients I haven't changed the protocol because they did respond well, and there is variability in the different month. It's a different month, a different group of eggs, and I have seen patients do the same protocol and respond differently and have different numbers of healthy embryos. But that having been said, it's always important to evaluate that first and make sure you're making that right decision. That's why, again, we always like to have a conversation with you. If something was abnormal with my hysteroscopy appointment, would I have to schedule another appointment for a procedure at a different time or same day? So if the hysteroscopy, if you're awake for it, yes, because we can't remove, we need to, it would be very painful, and we don't have, a lot in the office. We're doing the diagnostic hysteroscopy where we can take a look and see for sure if there's something worth taking you to the operating room for you going under anesthesia. If you're already under anesthesia, then we can just take care of it at that time. But typically, most people don't just put you under anesthesia unless, I've had some patients who have difficulty with pelvic exams, who have a lot of anxiety, and we might do that for them, and that's fine. I do agree with that. But for most patients, some ibuprofen or some pre-medications could help out. And it's a very thin camera, a very short, quick procedure to take a look inside, and then we can decide, hey, do you actually need to do anesthesia for this and go to the operating room? That's a great question too. And thank you so much for all the sweet messages. I thought this was would you recommend IUI or at-home ICI for same-sex couple? What's the difference in those success rates? So this is a really good question. I would say, so just to explain to everyone, IUI is intrauterine insemination and ICI is intracervical insemination. So I have had some of my same-sex couples who wanted to, who were not interested in doing a lot of testing, did not want to come into the office, have obtained, those samples at home for intracervical insemination. There's a couple of just things to think about with that. I have had patients actually, they did that on their own and they came and told me and they were pregnant, and I was really happy for them because of course you're always going to be happy for people when they're pregnant. The one thing is, it is important to know that even if you don't have a diagnosis of infertility, you don't know if you have a problem you didn't know about, right? So you could be buying those really expensive samples, and then what you do is you time them with an LH kit at home, with the timing of ovulation, but then you're just injecting that into the vagina, and then this is a sample where they wash it differently so that sperm can still try to make it through the cervix. With the IUI, we're actually taking a sterile catheter in the office, and we're placing it through this, like through the vagina, through the cervix, all the way up near the openings of the fallopian tubes. So that's it's important to know that it's getting exactly where it needs to be at that time. Now, what are, again, the success rates are still going to depend on age and what the diagnosis is too. So that can vary. Probably your IUI is going to be a little bit better than the ICI, but with no other infertility issues, you may have, as long as you're getting that sperm there. But again, are you putting it where it needs to be? Are you timing the ovulation right? And so that's a benefit we have in the office, where we can do some testing before then and make sure you don't have any roadblocks. Because I have had some of my wonderful couples who, think they have no issue, then find out, oh, I do have an egg reserve problem, or I do have a blocked tube. And so that would be hard to spend all that money on the donor sperm and then find that problem out later. But it always is good to have a conversation. And again, I believe in you doing what's best for you. So I counsel you. And of course, I think it's better if we treat you to get that sperm exactly where it needs to be and make sure you have the right evaluation and the right treatment. But I've had people who have been successful, which has been really fun too. So I'm always happy for them. How do you know if your eggs are good quality? That's a great question. So we have all the eggs we're ever going to have when we're born. It's really not fair. So the most eggs we have is when we are 20 weeks in our mother's uterus. And unfortunately, they decline over time. And the steepest drop is actually between 20 weeks and birth, which is also not fair. And each one of us has a different slope. That's probably influenced by genetics, environment, a lot of factors we don't know about, but they can decline in number and decline in quality as we get older. So the older you are, the more likely you have abnormal eggs. So we do have some tests of ovarian reserve, but they really aren't a great quality measure. But I will talk about those. It really is dependent on the age. So it's probably better to have a little less eggs, in a younger patient than a quote normal egg result in an older patient, someone who's, 43, 44. That doesn't mean, unfortunately, the age is the primary predictor. So, again, each person is an individual, and it's always important to have a conversation with the doctor about what do these egg reserve tests mean. So since I started talking about that, we'll talk about egg reserve tests. So egg reserve tests do not predict whether or not you're going to have a baby, but they do predict response to treatment. And so we have three main tests we do. One is the day 3 FSH, follicle stimulating hormone, and estradiol. And this is sort of a measure between the crosstalk between the brain and the ovary. So at the beginning of the cycle, FSH goes up a little bit, and it, the brain signals to the ovary to get a follicle, to recruit those follicles and get a follicle to grow. If the brain isn't getting that sufficient feedback from the ovary, the brain is going to almost like scream at the ovary to work. So some people say that might be like an elevated FSH may be a sign of a little lower egg quality. Again, it doesn't predict whether or not you're going to have a baby, but it can tell us if there's, some sort of decreased egg reserve starting, or for some patients where the FSH is higher, maybe some sort of like early, menopause. Remember, we always say premature ovarian insufficiency, not failure, as I've had many patients who are young with elevated FSHs who still conceive, right? But it is important to know because it may be more difficult and you may not respond as well to treatment. And again, the age is the primary predictor. So we do test we said day 3, but it can be done on day 2, 3, or 4, FSH and estradiol, to see how are the brain and ovary talking to each other. And so we do want the FSH to be lower. Typically, every lab is different. You have to look at the immunoassay of the lab. What are the lab parameters? But for most patients, something under and under 12 or under 10 is normal. But again, you have to look at the exact lab, and they have those parameters there. And the estrogen should also be low at that time of the cycle. You don't want that follicle recruited too fast, too soon is also a little sign of a dysfunctional cycle. So the FSH and LH should be lower, FSH and estradiol, should be lower at day 2, 3, or 4. Again, they're going to vary, and it's going to vary month to month, and it depends on the day and the time of day. You can always get a different result, so that's not going to stay the same. There's also something called an AMH, an anti-Mullerian hormone. And this hormone is secreted by the cells that support the egg. And it kind of gives us a sense of the basket of eggs. And there's certain medians, if I can give you age ranges of what's kind of the 50th percentile for an age range. But again, it's important to know that this does not predict whether or not you're going to have a baby. I have patients with low AMHs who've gotten pregnant on their own, and patients with normal or high AMHs who are having difficulty with IVF cycles and egg quality. So it's not a marker of egg quality. We also do an ultrasound to at the beginning of the cycle to get the antral follicle count. What is that? So out of all the eggs, the whole bank of eggs you have, a group of eggs gets pushed to the surface every month. And this is that group that's going to be kind of in play for the month. But in the natural cycle, one of those is chosen and the rest die. But that number, that follicle count, is also a surrogate marker for our egg reserve. So typically we think a total number, both ovaries together, less than 6, maybe lower, but that might not be abnormal for someone like me in my 40s, right? And for someone who's younger, maybe they should have more like 10 to 20 or so, but everybody's different and every month is different too. So that's important to know. So again, age is the primary predictor, but we can get these egg reserve parameters to see, okay, where are things for you? What is the prognosis? Maybe what treatment should we recommend? How might you respond to a cycle? What kind of protocol should we do? So they do give us a lot of information, okay? Is there a suggested or preferred number of embryos per live birth? So we do, the best recommendation I can give you, the safest thing is to do a single embryo transfer. So one embryo at a time is important to minimize, the risk of twins and triplets, because once we're putting more than one embryo in, we are increasing the rate of twins and triplets. Now, I know a lot of people tell me, they're like, oh, Dr. Bachman, I would love twins. Like that would make things so easy for me. And I say, if they're healthy and you're healthy, that's great. But we do know that unfortunately, twins have a much higher risk of miscarriage, preterm birth, developmental issues, gestational diabetes, preeclampsia. So we all know people have healthy twins, and that is wonderful, but there are increased NICU admissions. So we don't want to cause the problem. Remember that even one embryo can split on its own. So I've had many identical twins out of one embryo, so that's still possible. But there are certain situations where maybe if someone's older and they're not testing the embryos, so ASRM does have criteria for the number of embryos. So in a young, good prognosis patient, we recommend one embryo. If the embryos have been tested and we know they're genetically normal with the 98 to 99% accuracy, as we know it's not perfect testing, we recommend one at a time across all age groups. We recommend one at a time for donor egg. We recommend one at a time for a gestational carrier. But I have had some patients where, appropriate counseling, or we've talked about things, or maybe they've had transfers that did not work, or they're older and they do not want to do genetic testing, we may put more than one, and we usually use the ASRM guidelines for that. This is an awesome question. How do you know when the right time to trigger is? What are you looking at, egg size or labs? So I look at both, right? So there's a lot of things that I look at, and I look at the number of days someone has been stimulated, the growth of those follicles, what are the majority of those follicles, what are the sizes, where are the estradiol levels, where is the progesterone going? So I take a lot of things into account when deciding when to trigger. And this is going to be different between patient to patient, sometimes based on age too. So I usually try to get a good number of mature eggs. We think that the ones that are over 15 millimeters will have the mature egg, but we do want to see more of them in that 18 to 20 range. We do want to see that the estradiol levels are appropriate. Sometimes you can see maybe you're not getting the sizes you want, but that estrogen is plateauing. The body may be saying, okay, it's time. So there are a lot of factors that go into this. I also might let's take a step back and say, has this patient done other cycles? How did she do in this cycle? How many mature eggs did she have? How many fertile, like what happened in that other cycle? And then can we compare this cycle too? So there actually are a lot of factors. It's not just one. So we really take time to think about it and to make the best decision for you. Oh, that's so sweet. Oh, that's so sweet. I did your surgery. I would love to see you again. Oh my gosh, that would be amazing. Best way to explain a mock transfer to other people. Okay, so a mock transfer is sort of a trial run of the embryo transfer. Some offices do it, some offices don't, and that's okay, you know. But what we do is we take a sterile catheter that has nothing in it, and we just basically, when your bladder is still full, we put a speculum in and we gently place the transfer catheter in to measure the uterus and to see if it's difficult to get in. So typically an embryo transfer is done when you're awake. It should not be too painful. Rarely I've had some people have very difficult transfers where they may have some cramping, but we ideally don't want much cramping. We want it to be, not painful. It's not like an egg retrieval. There's no needle. It's not like the HSG. It's not crampy like that. It's totally different. But the one thing is you do have to have a little more of a full bladder so that we can see abdominally, see the uterus well. And so for some patients where their uterus is going this way, it's anteverted, it makes it straight. This is a mirror image of myself. I'm going the wrong way. Okay, but it makes the uterus more straight. And then we can gently place the embryo in. And I've done a ton of mock transfers, but I have to say sometimes it's just a little different every time depending on how full or not full the bladder is. And so we always do the transfer under ultrasound guidance. So we want to see that catheter, see where we're putting it, see that flash of the fluid, gently remove the catheter, and then have the lab check and make sure that embryo came out. But the mock transfer can help us to see if we're encountering any problems beforehand so we can plan for that. But I will tell you, some offices have so many cycles they're not doing them, or sometimes they're doing it right at that time, and that's okay, right? There's different things, and I'm sure someone sometimes the IUI is also very similar to that. When you're trying an IUI, it's very similar, but we do like to make sure that it's easy to get in. After a single embryo FET, how soon would you know for sure that it's split and there's twins? It would be at your first ultrasound. You would know if there are two sacs or not, or if there's two. So typically once you get to that, between 6 to 8 week ultrasound, we should be able to know if there's two sacs or two babies inside. Okay. I don't know. Oh, that was so nice. Thank you so much for saying that. Is IVF the only way to conceive if your tubes are blocked? This is an awesome question too. If they are definitely blocked, then unfortunately, yes, it would be the only way to get pregnant, where we can take the eggs and sperm outside of the body and do what would happen in the tube in the lab and then place that embryo in the uterus. For some patients, if they're not sure, sometimes we can do a laparoscopy to see, are the tubes really blocked? Is there something we can fix? And so sometimes for, maybe a test that was wrong, all these tests do have some, false positives. So sometimes people spasm because it's really painful, or, it's an ultrasound or an x-ray. So it's nothing those aren't perfect, but we can do the laparoscopy to take a look if it's something like, hey, I'm not sure if I want to do IVF. Sometimes when there's a minor abnormality, we can try to open up that tube. But it is important to know that if a tube is really intrinsically damaged, just because fluid goes in from one side to the other doesn't necessarily mean it's functioning. So that's where sometimes IVF is going to give you the best chance for success. But it always is good to look at your individual case. What are your wishes? And talk with your doctor about those, those options. But yeah, if the tubes are not open, IVF is going to be your best chance. Oh, I love this. I was told mine were blocked and I have a 1-year-old baby boy. I love that. So see, again, nothing's perfect. As I said, I've definitely had patients where that has been the case. And, again, none of these tests are perfect. You might have had a spasm. It may have been not on the ultrasound. So the tests they're screening tests, right? That's important to know. But the laparoscopy can tell us more if you want to know that. Should having a fibroid be something to be worried about when going through IVF? This is also an amazing question. Fibroids are a big topic of conversation. It all depends on where is the fibroid and how big is the fibroid, right? And how many are there? And also, are they causing you symptoms? So we know for sure fibroids that are in the lining, that are actually in the lining, we do want to remove those because they can affect implantation. But if they're outside and they're kind of in the muscle wall or outside the surface of the uterus, they may not be affecting implantation or where the tubes are, or your fallopian tubes. So we might not have to do anything about that at all. Over 50% of women have some fibroids. And if they're small and not causing symptoms and not in the lining, then many times we don't recommend that they're removed. If they're larger, they're distorting the cavity, they're causing symptoms, then we do want to do that. So it all depends on the location and the size. Oh, that was so nice. Thank you so much for saying. I'm happy to see you again too. That's wonderful. So I think I answered most of the questions. If not, you can always send us your questions, and we're happy to answer them. I really appreciate all of you being here. Again, I wish you could talk back to me because it's been very strange talking to myself. But I hope this was helpful. And if I would love to meet you in person, and please let us know, if we can help you with anything. Okay. And yes, and we will be expanding Milford more too. I see that. And then do we do donor eggs? We do donor eggs. And yes, I'm so happy. Yes, there are ways to, again, for if the tubes can be unblocked sometimes, and I think that's great to tell people that can happen. And we do want to, again, it's an individual basis to see what's happening with how extensive that is. But I'm very happy for you that your tube was unblocked. That's wonderful. I think that's all. Okay. Well, thank you all so much for joining me. Again, I really look forward to meeting you all, and please let us know if we can do anything for you. And thanks for taking your time. I'll see you soon.